Hi, we're coming from the Alice and Charles Palmer Cardiovascular Suite. We are going to be performing a valve replacement procedure today, which usually requires incision and an open chest. But the procedure that we will perform today is called a TAVR, or Transcatheter Valve Replacement. This is a minimally invasive procedure in which we gain access through an artery in the leg, and that's how we place the valve in this patient. Our patient is a 64-year-old who has multiple conditions that would make him a high risk for traditional surgical valve replacement. He's a very brittle diabetic, and he's had uncontrolled hypertension in the past. In addition, this patient has already had previous open heart surgery, a bypass surgery. And when we go and perform a second open heart surgery, that really enhances or heightens the risk to these patients. And finally, this patient has had multiple abdominal surgeries. The patient has spinal problems, which would make recovering an individual like this after open heart surgery very difficult. I'm joined by Dr. Riley and Dr. Burke. Dr. Riley, would you please describe how you achieved access in the artery of the leg so that we could implant this valve in this patient?
We are not going through the chest. We're doing this whole procedure through the groin, and we have a catheter in the groin already here for prep, and we have a catheter in the wrist over here. So between those two access points, we'll perform the valve implantation.
And so on the screens to the left, we have X-ray, moving X-ray, which we call fluoroscopy. To the right, we have ultrasound or echocardiographic imaging, and no one better to explain what we're seeing on the echo images than Dr. Burke. And in fact, I think what you and I ought to do is start doing our procedure, getting our catheters in place. And Dr. Burke, could you explain the fluoro and the echo, please?
So fluoro, that's the X-ray imaging that we have, and so we can see straight through the body. In this case, you can see some wires there that are from the prior sternotomy. That's where he had his prior open heart surgery. And then we've got some wires and tubes inside there. Those are the catheters. And that allows us to see exactly where tissue is going to be. So unfortunately, the heart is invisible on X-ray. You see right through it. And that's why we have to use echocardiography. That's the ultrasound that I'm using right now to be able to look at the valve and see exactly where it is and also where these catheters are. So that's how we help to guide the procedure. And what we're looking at here on my screen is the aortic valve. On the left side, we're sort of looking down on the valve itself. And on the right side, we're cutting through it at a 90-degree angle.
What do you need?
Wow.
Balloon,
so we
please?
can also throw
Balloon?
color on here that shows blood flow. And in this case, you can see that there's blood flowing backward because we're actually splinting, we're keeping the valve open even when it would otherwise be closed. And that's because of the wires.
Dr. Burke, you've shown us all that calcium on the valve, and before Dr. Riley and I made the decision that before we just proceed with placing the valve, that what we should probably do is try and balloon this this catheter, or use a balloon catheter to dilate up the calcified stiff valve.
Absolutely. You can see calcium right there and there and there.
So if you can show this balloon close up, we're going to move this balloon all the way up. Go ahead, Bob.
This is on the wire right now.
There, that's perfect.
And then we'll pass that through the catheter, the sheath that's already in place here.
Fluoro.
And then we'll look at the fluoroscopy machine ahead of us and pass it to our mark.
Wait 1 second. Now, Dr. Riley is in position 1. He and I alternate who's going to be in position 1 and who's going to be in position 2. Position 1 really positions the valve. Position 2 is the one that unrolls the valve into the valve complex, the old valve.
And here on the fluoroscopy, we have these two markers that show the beginning and end of the valve, and we'll just right now pass across where that little curly Q catheter is, the pigtail catheter. That's sitting where the native valve is. So we're halfway across it right now.
And you can actually see calcium where that, go on fluoro. You can actually see calcium on that. Go ahead and run that, where that pigtail catheter, that curled up catheter is, you can actually see calcium. And we're going to try and crack that calcium with this balloon before we go in with the TAVR valve.
So while we're doing that, we'll ask the anesthesiologist to pace the heart at a fast heart rate so that the valve and balloon don't move, and then we'll inflate it with this syringe here that Dr. Rizik has. So Dr. Harrison, if you'll hold respirations and then turn the pacer on at 180. So we have good pacer capture, and now the balloon is going up. And
there, we cracked the valve pretty well. Now the balloon is coming down.
Pacer off.
Balloon is coming down.
And fluoro save that.
The valve might not sit right, and it might not open up perfectly. Fluoro, please. The valve might not open up correctly because of that stiff calcium. So we're going to crack the valve first before we go in. We're going to crack the God-given valve before we go in with the new TAVR valve.
So now we're going to take out the catheter that was our placeholder and put the valve in through that spot in the groin.
And you can see this is like a, what do they say, a four-handed piece of music. Dr. Riley and I are moving, all of our movements are together.
Okay, you want to back it out?
Yep. All right. Tell me what you think about my wire position. I think we're in good shape.
Okay, I have wire.
Okay. And Sophia, who's very experienced, is going to hand me my valve now. She's going to start it on the wire. All of these valves, like the previous devices that you've seen us use on the procedure, everything goes over a wire. So not unusual for these types of procedures. There's a wire all the way up to the heart, and this is going to similarly go over a wire up to the heart. Dr. Riley is going to do most of the positioning. He's going to decide where the optimal position is. Sophia, hold that wire. And then what I'm going to do is I'm going to unfurl the valve once we're adequately across. Wait 1 minute, Bob. Okay, go ahead. I'm ready for you. I'm going to unfurl it as we get into a proper position at the old diseased aortic valve. So you can see at the bottom of your fluoro screen the catheter coming up, the new valve coming up, okay? All right, Bob. Got my wire position.
Yeah, we're going to move the pigtail a little bit, but
Okay, go ahead.
pull wire back a little bit.
Okay, wait, Flora. Good, good, perfect. Okay, good.
Implant angle, please.
So now you see that TAVR valve. Now let's do this. Give me a little toot. Give me some contrast. That worked perfectly.
Yeah,
All
we
right.
don't even have to move.
All right. So, Bob, I'm going to do this. You be the captain on this one.
Okay.
You make the call when you want pacing and everything. So we have one person communicating as we do this rather than multiple people.
So let's pull the wire a little
Okay.
central.
All right.
Dr. Harrison, will you turn the pacer on at 120?
You like that
That'll-
wire position, Bob?
Yes.
And Bob and I just alternate who's going to be in position 1 and who's going to be in position 2. That's the best way a heart team works. Everyone can do every job in the room.
So now you can see that there's less motion, so we can keep our marker right there at mid-pigtail, and then we're going to open up the valve. If you look at Dr. Rizik's hands, he's twisting this, and it's kind of pushing the valve, or unsheathing the valve, pulling the catheter off the top. So we're a little high. I'm going to come down to right about there.
Now, you notice what Dr. Riley just did. While I'm unfurling the valve or opening the valve,
Pull the wire in a little neutral.
you do the wire, okay, Sophia? So it's really becoming a six-handed procedure.
Let's hold here. Dr. Harrison, let's pace at 150. And this valve is repositionable, so if we don't like where we land, we can always recapture and put it in a different spot. Pull wire, Sophia.
Oops.
All right, now push it in a little bit, Sophia.
What do you think, Bob?
Yep.
Okay, I'm going to keep going. And this is just a nice casual pace that we're not a rushed procedure, just a casual pace. And you hear that rumbling sound. That means you're near the end of travel for this
Okay,
valve.
pacer down to 100, centralize the wire.
Dr. Burke, would you mind stepping in and telling us what you think about the depth of this
Off
valve
on fluoro,
implant?
let's do a cine so you can see
So
it a
on
little
this
bit.
image right here, you can actually see the valve. We're sort of looking at it, cutting it right through the middle. You can see where the valve has landed here. It's just below the actual annulus, just a tiny bit. And that's really where we typically like to see it. Looks like that's opening up very well right now. Now, don't forget, this is a memory metal. It's nitinol. It's going to expand over time, and it continues to do that because it wants to get back to its original shape.
That's a very, very, very important point. When we put this in, nitinol or nickel titanium, is when it's cold, they prep it in cold water, it's very small. Dr. Riley, what happens when it comes in contact with the warmth of the blood, 98.6 degrees Fahrenheit?
So it will return to its natural state, so it'll expand.
Right. Okay.
Let's push wire a little bit, see where we come down to 80 on the pacemaker.
Dr. Burke, our depth, are you happy with that?
Looks like we might be a little bit deep there below the left.
So,
right
Dr.
now.
Riley, do you think it'll come up on release, or what would you like to do?
I think that let's do a different modality. Let's go ahead and inject contrast here and see our depth based upon the fluoroscopy as well.
You ready? Go ahead.
I think we're talking the difference of millimeters here. I think that
Pretty happy with the way this looks. What do you think? What would you do if, what do you think we should do? We have the option, I asked Dr. Riley that, we have the option of recapturing this or deploying it just like it is. So what should we do?
just still debating whether we should make it 2 or 3 millimeters higher.
Okay, then I have to say we do it.
Okay, all right.
Okay. So I am going to recapture this valve.
Centralize the wire so it doesn't become aortic.
Okay.
Pace at 120, please.
So now you can see very easily I'm reversing directions with my dial and we're recapturing the valve. And we can do this multiple times until we perfect the position of the valve. And Dr. Riley has probably the most important job right now. He's trying to make sure that valve stays centralized and doesn't dive into the pumping chamber or into the aorta. What do you think about that?
Right
depth
about there.
Okay.
Yes.
And what do you think about our wire there?
Let's
Dr.
check
Riley?
our pigtail catheter.
Okay, let's give a toot there. I think that may have, actually it's perfect. Oh, that looks perfect. Okay. Pace at about $1.50, please. And
So Sophia, we're going to pull the wire a little bit here. Stop.
I love your depth right now, Dr. Riley. I love the depth. So now I'm going to move a little bit faster in deploying this. Now, Dr. Burke, you're up again.
Pacer down to 90. So I think we moved the valve up of probably 3 or 4 millimeters.
It looks like a substantial movement.
So the
Dr.
pacer
Burke?
to 80.
This is looking great. Might have a little trivial leak there, but
Centralize the
that
wire.
will typically go away over time as the valve continues to expand.
Boy, I love this. I think this is a keeper. What do you think,
I think
Dr.
I'm going to
Riley?
lay over a little bit while you release it.
All right.
And we'll release it with pacing again. What do you
Okay.
think?
Why don't you make the call?
So let's pace at 180.
Are you on, Bob? Yeah.
Yep.
Yeah, bud.
Centralize the wire a little bit, and we're going to release very slow, and you'll see at the top of the marker here, the valve will open up there.
Oh my goodness, look at that. Okay, I'm still on one.
And-
I think it just gave.
Still have to call it.
Okay. So do your thing, Dr. Riley. Go ahead and drop the pacer a little bit. There it is. Now we just released.
All right, centralize the wire.
Okay. Okay. You want to retrieve? And there it is. So now the valve is out. All right, fluoro, please.
Live.
Live. Show that, please.
Come down.
Aaron, come down, please. Thank you. That's perfect. Perfect. Okay, may I have an 035J wire? You can take that. Dr. Burke, position.
This looks great.
Okay, could you, I'm going to fluoro now, could you go up to the new valve? Now you can see Dr. Burke's probe is there. Bob, come back just for a split second.
Let me have a J wire, please.
Okay, now I'm going to do a cine.
Let me have the short J.
Capture this. And there's the new valve. When we perform surgery, Dr. Riley cuts out the old valve, correct, and sews in a new valve.
Correct, as opposed to wallpapering over it.
We just push the old valve aside, put a new valve in over it, and that's it. We have a beautiful result, which I think will serve this patient very well. We will take the patient off the table and hold pressure on the leg, and within 4 or 5 hours, this patient will be up and around. Most of our patients go home either later in the same day or the very next morning. This is a very innovative procedure, and it's very new, but we can only offer this to our patients through the generosity of our donors, and we thank you very much for giving us this opportunity to help these patients.